Dear colleagues, friends of swept source technique, thank you, board, for giving me the opportunity to present our data on detection of treatment-naive ZNV in AMD by swept source OCT-A. And this is our study group, and I think Carl doesn't need any introduction. So our institute currently receives a research grant from Topcon Europe. Of course, if we're talking about AMD and OCT-A, I think it is essential to differentiate between studies based on spectral domain instruments, which are quite numerous, and swept source-based studies, where those numbers of eyes that were investigated are fewer, and the results are quite varying and sometimes inconclusive, at least concerning sensitivity and specificity. And that is probably simple due to the fact that there is, I think, only one swept source-based machine available commercially at the moment. So we came up with our own study protocol, and we investigated treatment-naive NAMD patients with conventional multimodal imaging, the spectralis from Heidelberg, and we investigated all anatomic types of CNV, and they were reevaluated by the swept source OCT-A machine. We used the spectralis with a true tracking device and a 30-degree angle that has the simultaneous OCT-B scans, and they are spectral domain-based. And we opposed them to the swept source OCT-A from Topcon. We used Smart Track and the automated artifact removal option. We used 4.5 and 6 millimeter cubes, and what we considered the semi-automated segmentation, meaning we just take the segmentation lines from the machine and alter the height to get different slab sizes. Or we did manual resegmentation, meaning that we redraw the lines by ourselves. And we did a masked binary grading with CNV positive or negative by a masked medical retina specialist. So we included 156 eyes in 98 patients. Enrollment was 1 year, and these are the descriptive data of our patients. I want to give you some examples. This is a 75-year-old male with an NAMD on his right eye with some, I'd say, large, soft drusen. And if we take a look at the angio pictures, you already see some speckled hypofluorescence, I would say, that becomes more intense in later phases. You have an ill-defined kind of CNV membrane in early ICGA, and also in late ICGA. So this is CNV type 1 in our opinion. And we could clearly depict this CNV within a choriocapillaris slab underneath those projection artifacts. I give you another example of a 76-year-old female with an NAMD on her right eye. Again, there is some degenerative debris, and you see actually, in our definition, two CNV structures. One is leaking quite early and has well-defined borders, whereas the other is rather ill-defined. And this leakage gets more in the later phases, and you have this quite nice border of the CNV membrane with a halo in ICGA. So this is what we consider CNV mixed type. And we could also depict this CNV structure quite nicely by the choriocapillaris slab. And you see this slab, this is what we consider semi-automated segmentation, where we just alter the height to get underneath the RPE. And if we're taking the autoretina slab of the machine, then we try to get just the subretinal part, which is hardly possible. So that is probably not one thing that the machine is able to do. Nevertheless, that is clearly depicted. And that's an interesting case. That's a younger patient. She's 61-year-old, and she doesn't have too much of degeneration, but you can already see this this yellowish half-moon shaped kind of elevation on the fundus photography. And when you look at the early FA pictures, you already see evidence of CNV, and there is some pooling in the later phases. So this is, you see the margin of the CNV membrane in ICG actually within the hypocyanisance, and this is what we consider vascularized PED. And the machine does have problems with this type of CNV. So we did manual resegmentation where we redraw the line underneath the high PED, and you see some, I would say, projection artifacts on top of this PED, but that is not CNV architecture. So these are our results. Sensitivity was 76%, so 81 of 107 eyes compromised by CNV could be detected by the swab source machine, meaning 26 of 107 were not detected, and specificity was 100%, so all control eyes were excluded regularly. We did the univariate analysis, and we did a sub-analysis for no PD versus low PDs, and low PDs versus high PDs, meaning PDs over 400 microns. And again, we opposed CNV type 1 to all other CNV types. And with these numbers, we did a multivariate analysis with similar results. So in 81 out of 107 eyes, CNV could be detected in treatment-naive NAMD, leaving 26 eyes behind, and 24 of them were complicated by CNV type 1 that could not be detected. 9 of 12 eyes with a PED height over 400 microns could not be detected. These are the bar graphs that illustrate our results. And to conclude, in our study, swab source OCT-A was inferior to conventional angiography for the detection of active treatment-naive NAMD. And that means angiography still remains the gold standard at the moment. We had difficulties with high PDs and CNV type 1s. Nevertheless, it is a non-invasive, fast detection device. It's easy to use, and it should be installed as an additional first-line multimodal imaging tool. And this is our study that was published in September last year for everyone who's interested, and I want to thank you for listening.